Hello. So today we look at low birth weight, prematurity, and post-maturity. Okay, as usual, your presenter, Mr. Jones. Okay, so we move on. So low birth weight or prematurity. By definition, what is meant by low birth weight? So this refers to an infant weighing 2.5 kg or less at birth, regardless of the estimated period of gestation. Please, you need to mark these parameters 2.5 kg or less. Okay, and it is regardless of the estimated period of gestation. Okay, so now let's look at the classification of low birth weight. So, one, when a child is born after 28 weeks but before 37 weeks of gestation, this is what we call prematurity. 28 weeks but before 37 weeks of gestation. So, this parameter is what we need to keep in mind when you're talking about prematurity. Then, when you're talking about small for date or light for date, we are saying when an infant is born at the right gestation period but with a low birth weight, this is what we refer to as small for date or light for date. Okay, so on prematurity, you have to note that the child should be weighing 2 kg or less. Okay, so that is also another parameter that you also need to notice on to note for prematurity. Okay, when you talk about post-maturity, we are saying a baby born after 42 weeks of gestation that is calculated from the last normal menstrual period. Incidence of this condition is 10% of all live births, or of all live births are premature, whilst 5% are post-mature. Right? So for premature is 10%, whilst 5% can be post-mature. Okay, so now let's look at the causes of prematurity, small for dates, and the like. So one of them, the causes can be grouped as one, maternal factors. So that is age outside 20 to 35 years. Okay, it predisposes one to having a premature baby. That is when they are of age outside 20 to 35 years. So, getting pregnant early before 18 years or so, or before 15 years or so, predisposes one to have a premature baby. Or having your first child after 35 years or so, we can predispose one to having a premature baby or small for death. Then maternal diseases like chronic hypertension predisposes one to having small for death, and pattern hemorrhage, preeclampsia, diabetes mellitus, heart diseases, chronic nephritis, malaria, placenta previa and abrupto, syphilis, bad obstetric history due to recurrent premature labor, low socioeconomic factors, and multiple pregnancy. So if we look at the predisposition factors here, when we look at all these conditions, they may affect the metabolism, so the baby will not have sufficient nutrition that it needs, or it may affect uh, the nutrients that are going to the placenta meant for the baby. So when you have these conditions like malaria and the likes, okay, so someone had bad history that is due to recurrent premature labor, so that also predisposes. And when you look at multiple pregnancies because of pressure, there may lead to prematurity space because of limit of space. Low socioeconomic status has to do with poor nutrition, mostly during pregnancy. Heart diseases, which may lead to insufficient oxygen going to the baby. So that is what we can talk about there. So let's look at fetal causes. So first, we discuss maternal causes. So we have maternal causes, fetal causes, and there down we have uterine causes. So now we are on fetal causes. So congenital malformation, that is hydrocephalus. We can also have genetic abnormalities like Down syndrome, may lead to prematurity or small for death. Intrauterine infections, that is, for instance, from rubella or toxoplasmosis, syphilis, or HIV, may lead to small for death. Growth retardation, placental insufficiency, and rhesus factor incompatibility, all these conditions may lead to small for death. Now, let's look at uterine factors. Uterine malformation, for instance, in bicondylitis uterus, baby may be born prematurely, or you can have a small for death baby. Cervical incompetence causes one to go in labor early, hence you're going to have a small for death baby. Every rupture of membranes before the before the woman is due may also lead to small for deaths or prematurity. So every rupture of membranes, and then we have fibroids that affect the space for the growing baby, leads to small for deaths or prematurity. Multiple pregnancy because of pressure, because we have two babies there, so space becomes limited. There's competition for space. All right, so maternal, okay, we have looked at maternal, fetal, uterine. Now we're looking at socioeconomic factors. So poor nutrition, as we know, there's increased demand for nutrition during pregnancy. So poor socioeconomic status during pregnancy, failing to meet the nutritional demands of pregnancy may lead to prematurity. Lack of good antenatal care, during antenatal care, women are taught a lot of things. So if there's no good antenatal care to help preserve the life of the mother and that of the baby, may also lead to prematurity. Heavy alcohol drinking and smoking, these affect the nutrition status of the baby, because the mother will not eat that much, so they will depend on the calories that is coming from beer. So the baby also will not feed a lot. Okay, so the baby will not feed a lot. So then let's look at the clinical picture now. So for the heads, okay, so when we started pediatrics, we looked at assessment of the newborn, and we did that head to toe and the likes. My interest here is just to point out certain things in relation to the condition that we are discussing. So for the head, it is larger than the body and the chest, and cranial bones are soft and fontanelles are widely separated. Okay, hair is very soft, ear tends to stick after lying on it. Then when you examine the skin, or when you assess the skin, it is wrinkled, delicate, and soft due to lack of subcutaneous tissue. And the color is red, and there is plenty of lango, with a little vernix caseosa, that whitish stuff. All right, so assessment of the limbs, they look thin, fingernails are soft, okay, fingers, they are long, the plantar creases are absent. Movement of both limb and body will tend to be a frog-like position due to poor muscle tone. The behavior is dull. The baby is dull. That's what we can just describe it. And then because of premature nervous system, okay, premature or immature nervous system, maybe that's all we can put it, immature. All right, then the trunk chest is small and narrow, less firm. Abdomen is large, and the breast nodules are present. When you examine the umbilical cord, it's lowerly six. Muscle tone, it will be poor sucking, and motor reflex may or may not be present. Right, then in examining the genitalia, For female, labia majors does not cover the labia minor. And the labia minor is larger and protruding. For the male, testes are undescended into the scrotum and genitalia is small. Neurological assessment are sucking, swallowing, and all the normal reflexes are absent. On doing some measurements, the head circumference is less than 35 centimeters, and the length will be less than 27 centimeters, and chest also be less than 30 centimeters. So I will encourage you to look for the other lesson where we talked about the assessment of the newborn. But I know you can remember from class those conditions that we covered on assessment of the newborn and the parameters that we talked about for the new normal for the newborn. All right, so let's look at the care and treatment of premature baby. Okay, care and treatment. So, first point to note is that due to increased mortality rates among premature babies, despite adequate care, effort should be made towards the prevention of prematurity. We say prevention is better than cure. So it's better when you have someone under your care who belongs to the risk areas, we try by all means to prevent them from having a premature baby. Otherwise, there is special medical and nursing care by medical team that improves the baby's survival. So let's look at it from now delivery. So all mothers threatened to have premature baby must be transferred to the hospital where there is a special baby care unit and trained personnel. Labor should be conducted in the maternity unit close to the special baby care unit. During delivery, the pediatrician should be available. Great care must be taken in labor, that is to avoid drugs that may depress the respiratory system like pathogen. So efficient care at birth, that's what can compose what we call efficient care. So efficient care at birth. So no nursery can provide nursing care equivalent to the uterus, but efforts should be made to have that similar environment of our first home where we all developed, which is the uterus. So the delivery room should be well prepared and should have a room temperature of 24 to 26 degrees Celsius. The resuscitative drugs and equipment should be readily available. And when we are talking of resuscitative drugs and equipment, what we necessarily mean is the cardiac stimulant drugs like adrenaline, 1 milligram, hydrocortisone, 12 milligrams, starts, respiratory stimulants, vitamin K, 0.5 milligrams start, which can be given, and antibiotics for prophylaxis. And in this instance, Expen or benzylpenicillin and gentamicin may be used because the baby, we said, is prone to infection. It's prone to infection. So oxygen cylinders, and it can be administered at 0.5 to 1 liter per minute. Okay, so resuscitatively, we are saying home portable incubator, that is 32 to 34 degrees Celsius temperature should be set there between. And these actually incubators, they have thermometers within themselves for monitoring and regulating. So suction machine is also important. Laryngoscope can be available, and intravenous set equipment also available. It's important to know how you are using all these things that are found within the resuscitative kit. So immediate care will include the following as we are expecting the baby who is now being born prematurely when it is inevitable. So the immediate care may include the following. That is, episiotomy may be performed to shorten the second stage, thus reduce the risk of intracranial injury. As soon as the baby is born, the baby is cramped and the baby is wiped. Okay, this is to avoid heat loss by convection. And extra gentleness and steps to prevent hypothermia, that is within the first 10 to 15 minutes, is important since the baby is prone to go into hypothermia. All right? So the baby should be covered warmly and saved in a warm incubator. And we have already set the incubator at 32 to 34 degrees Celsius. All right, so initiation of respiration. So suctioning should be done gently to remove mucus and secretions from the nose, or fine extractor may be used. So oxygen may be given at the rate of 0.5 to 1 liter per minute till respiration is well established and the color is satisfactory, so we don't want the bluish discoloration in the periphery, which is a sign of inadequate oxygenation to the tissues. So if the baby is severely asphyxiated, early intubation should be done and must be carried out in a warm room. So as soon as respirations are established, the baby should be wrapped warmly and put in the incubator. They have to also give vitamin K 0.5 milligrams IM, and this is given to prevent bleeding. Subsequent care. So when the condition stabilizes, the baby should be transferred to the special baby care unit in a portable heated incubator. Maintenance of respiration. So depending on the condition of the baby, there may be need to put the baby on continuous positive airway pressure, especially when it has difficulties in breathing. So the oxygen given should be humidified to avoid irritation of the airway and should be kept at 55 to 60%. So the color apex beat respiration and general condition should also be observed and recorded. Okay, so staff should be the only ones entering the nursery, and there should be only one baby in the incubator. So there should be only one baby in the incubator, and the room temperature should be 25 to 27 degrees Celsius, and the incubator should be free from infection. We're saying it should be well dusted before you receive the baby. So now let's look at maintenance of body temperature. So due to lack of subcutaneous fat, the premature baby tends to be hypothermic. Hence, the need to have a conducive room and an incubator. So the incubator temperature is recorded according to the baby's weight, and the heat radiating shields are necessary to conserve body heat. And the iris of the incubator should be closed immediately after attending to the baby because we don't want the warmth of the incubator or within the incubator to be lost out to the environment. Okay, so now let's look at the nursing care. So meticulous nursing care of premature baby is important because our main objective here is to maintain warmth, provide adequate hydration and nutrition, and to prevent infection. Other objectives that also need to be met is to promote mother-baby bonding, maintenance of hygiene, and also we have to give proper IEC or health education. So let's look at maintenance of warmth. So this can be achieved by making sure that the baby is not being overexposed, especially when carrying out procedures. So the baby's temperature should be taken from the rectum and recorded. So the normal temperature, of course, we know is from 36.6 to 37 degrees or 37.5, that range given to us by World Health Organization. So in rural areas, the baby may be kept in a carton box with cotton wool. The cotton wool acting more as a shield for warmth. Otherwise, that is more like talking about appropriate technology that is used in rural areas in trying to conserve heat for premature babies. So, an electric kettle may be used in the room to help warm up the room, and the kangaroo care, where the baby is kept closer to the mother's body at all times, can be introduced to prevent hypothermia. So, what is necessarily happening is that the heat from the mother or the one doing the kangaroo care is being transferred to the baby. So the baby is held like you're hugging the baby so that your heat is transferred to the baby. Since the baby does not have that good capacity to generate their own heat. So the baby should always have warm linen. Let's now look at nutrition and hydration. So on this one, we can say it is the nurse's role to give feeds according to how the baby tolerates and also the general condition. Sucking and swallowing reflexes are usually poorly developed, and the infant takes no response to stimulation of the lips by the nipple. Okay, that we call the rooting reflex. So initially, give baby sips or little water, progressing to glucose, and later express the breast milk. Okay, they are prone to hypoglycemia, so some glucose, intermittent glucose, can also be given to the baby. All right, so take note that stomach is small and feeds should be given in small amounts but frequently. So 2 to 4 meals of expressed breast milk should be given every 3 hours, and if child tolerates, increase to 10 meals per kg body weight, that is per feed. All right, so first and second, 10% dextrose is given to rest the river, okay, and hold the infant in and remember to hold the infant in semi upright when feeding, and should be done whilst the baby is still in the incubator. All right, so we can also ensure that after feeding the baby, we put the baby in a lateral position as it helps to straighten the duodenum. So the main aim of feeding actually is to prevent hypoglycemia and also maintain the nutritional status. All right, so lying of the baby laterally, you have to know that it helps strengthen the duodenum and helps the food to move now freely, nicely, without possibility of aspiration. Okay, so it's also important that we should know the principles of feeding. That includes the feed should be kept at the right temperature, and they should what I would want to say is they should meet the infant's requirements, and they should be digestible. Okay. Methods of feeding. How can the premature baby be fed? Okay. So this depends on the size of the baby, the condition, and the ability to suck or swallow. So all babies under 1.6 kg and those that cannot swallow are fed using a nasal gastric tube, abbreviated as NGT. Otherwise, the feed should be established immediately after birth to prevent hypoglycemia. Usually, babies that are born after 34 weeks of gestation, they will manage to suck from the breast. So milk is the ideal feed because it is easily digested. The feeds should be warmed before giving them and should be given slowly in small amounts. So they should be warmed for good peristaltic movement. It is called, it affects peristalsis or it makes it it becomes sluggish. So it should be given small meals, that is, you give the baby small meals but frequently. Investigations like blood electrolytes balance should be done to prevent metabolic disorders. Prevention of womb infection. Let's look at prevention of infection. So premature babies are prone to infection, hence the need of isolation in an incubator or room because of lower resistance to infection. So poorly developed immune system in these infants makes them susceptible to a lot of infections. So reverse barrier nursing is actually very much ideal. So no nursing or medical personnel with an infection should work in the nursery. Okay, I have an upper respiratory tract infection, the babies, they are likely to catch that. So hands should be washed before and after touching the baby because we are saying they are prone to infection. So you don't want to touch them with dirty hands. Hands should be washed before and after touching the baby. Alright, so each baby should have its own equipment to prevent cross infection. Rings, watches should not be worn in necessary. Alright, so sorry about that one as a spelling mistake. So should not be worn like wearing. So should not be worn in necessary. So there should be minimum handling of the baby and gowns should be worn when dealing with non-infected or infected babies. There are sexual gowns or sterile gowns that are worn in the nursery. Okay, so consider this sterile for prevention of infection. So the cord should be cleaned, cool, boiled water, and kept dry. Okay, so for the babies, that is what we do. So the cord is cleaned, cooled, and boiled, cooled and boiled. The incubators should be cleaned daily, and the environment should be kept clean at all times. All this is for infection prevention. Okay, so let's look at hygiene. It is not always necessary to give a full bath. So there is what we call top and tail, which is done always until such a time that it is ready to take a full bath because the baby is prone to hypothermia. So sometimes only buttocks and eyes are cleaned. So dirty linen should be changed, including dirty napkins frequently and disinfected. Observation and recordings. Observation and recordings. The nurse should be very alert and be able to note any deviation from the normal. During the first 24 hours, careful, frequent recordings should be done. The skin is observed for color, either pink or cyanosed, pale, rash, or jaundice. So the heart rate, respirations are also observed. Body temperature is taken by using a rectal thermometer. So analyzing temperature may indicate infection and reduced temperature indicates hypothermia. Observation must be done hourly, okay, then 4 hourly, okay, depending on how the need has been assessed. Otherwise, urine and stool should be observed and frequently noted. The baby's management should be checked on alternative days since drugs are calculated per body weight. So, and also a guide to food intake. So we are saying the baby's weight should be managed and checked on alternating days so that the appropriate dosage can be given and appropriate feeds can be given according to body weight. Okay, so now let's look at admission of drugs. So a premature baby is unable to detoxify or excrete drugs at the expected rate. Therefore, any drugs given to control bleeding and infection should be given at the right dose, time, route, side effects, and should be washed. Remember, 6 right dose, right time, those 6 rights we talk of in pharmacology. So should be given at the right dose, time, using the right route, and then side effects should also be watched. Psychological care. It's not easy having a premature baby because mother is like she's admitted. Yet she wants to do other business, but she's admitted in the hospital until time when they decide to say now they are discharging the baby. Okay, up to the time the baby has grown to a certain level. So the role of the mother should be encouraged during baby care. The initial separation, though necessary, can strain the mother, okay? But it's important for mother-baby bonding or baby-mother bonding. The mother should be welcomed and encouraged to contribute whenever necessary. She should be in contact with the baby as often as possible. This is because if the relationship is affected in the early stage, there can be effect on her mothering later, on how she takes care of the baby. So it's important that we create a very good bonding. So during the procedure, talk to the baby or talk to the mother. Of course, this is just about rapport. You know the baby cannot respond to you, but you can say a few words. Those words sounds try to stimulate the baby in one way or the other. So conditions for the removal of baby from the incubator to the cord bed. Conditions that have to be met so that the baby is removed from the incubator to the cord bed. So the baby is removed from the incubator to the cord bed under these conditions. So one is when the baby is able to maintain the temperature even when the incubator is off. That is one condition. Then two, when there are no apneic spells in the last 5 days. No breathing problem, apnea, absence of breathing. So third one is when there is a constant weight gain. When the baby is constantly gaining, then it can be one of the conditions. We're not saying we're going to consider one condition, but these conditions have to be met in one way or the other. We have to see at least an improvement in all of them, or if not most of them. Okay, so the fourth one is when there are no feeding difficulties. When there are no feeding difficulties, can also be one of the conditions for putting the baby in the cord bed. So after removal of the incubator to the cord bed, the baby should be observed at least for 24 hours, and if there are any abnormalities, it should be transferred back to the incubator. Okay, so now let's look at the criteria for discharge. We have moved the baby from the incubator to the cord bed. Now, what will be the criteria for discharging the baby? So the criteria include the following. When there is a steady weight gain, when the baby is able to feed well from the breast, meaning the baby is able to suck without any problems. When the mother has become capable to take care of the baby at home, when after you have taught the mother on how to take care of the baby, and she has gained proficiency on how best to take care of the baby, then it can also be one of those conditions. So when the mother has become capable, then we can start thinking of discharging the baby. So when the mother is able to bring the baby for review, we are looking at instances where the mother comes from very far, and we don't want the baby to be predisposed to infection along the way. So when the mother is able to bring the baby for review or monitoring and the likes, okay, then we can discharge the baby. We can think of discharging the baby. Okay, so now all that has been met, and now maybe we're discharging the baby. What health education can we give? to the mother? What health education can you give to the mother whilst in the hospital or upon discharge? What are some of the things that we can give in our information education and communication that is abbreviated as IEC? So, should start health education here. We're saying should start immediately the baby is admitted, that is the IEC, so that by the time the baby is discharged, the mother will be knowledgeable in the care of the child at home. So, in the IEC, as you are with the mother within the ward, or at the time you're discharging the baby, we're saying you have to tell the mother to avoid taking the child to overcrowded places because the baby is prone to catching infection. They also have to educate the mother on minimal handling of the baby by other people. This is also for infection prevention. Washing hands before and after touching the baby is also important for infection prevention, as the baby has low immunity. So, no overexposure of the baby when being bathed, and windows should be closed so that the baby does not go into hypothermia. So, you have to keep the baby warm all the times, and mother should be taught on the feeding of the baby. Okay, these are children of special needs, so this is a special thing that they need to know how best to feed the baby so that there's a good continuation from hospital to home. The child should be brought to the hospital for checkups or for review. Okay, so now let's look at complications of low birth weight. So respiratory distress syndrome becomes one of the complications, which is a major cause of death in premature babies. And in this condition, there is failure of normal surfactant, which serves to reduce surface tension and adhesiveness within the alveoli. Hence, the baby is prone to cyanic attack due to immature lungs and may have respiratory difficulties. Baby may have also repeated apneic spells that indicate poor prognosis or poor ending of the condition. So the first complication that we can see is respiratory distress syndrome, and then we can also see hypothermia. So which is due to immature heat regulating center in the hypothalamus, and this premature subcutaneous tissue which is within the baby also makes them prone to hypothermia. Infection. Remember, in our IC, we are talking about avoiding overcrowded places, washing hands, and the like. So, infection. So, we are saying this comes about as a result of premature baby being born before the immunoglobulin G, which is passed from the mother to the baby during the last trimester, has not yet occurred. So, the baby has weak immunity. Hypoglycemia can also be one of the complications as due to poor storage of glycogen because the baby has immature liver. Alright, so the baby may also have anemia, which is as a result of low iron, okay, as a result of short intrauterine period, so the baby may have low iron. So the capillaries are also weak and so they easily bleed. The other complication is a cerebral hemorrhage. Cerebral hemorrhage. This is a result of fetal skull, which is fragile and does not offer immediate protection to the brain and vessels, and hence the baby may become hypoxic or may have hypoxia. So they have a fragile skull, hence they are prone to cerebral hemorrhage. The other complication is edema, which is due to poor muscle tone, as it will lead to inadequate venous return, causing accumulation of fluids in the extremities. Okay, so other complications include recurrent fibroprasia or retinopathy of prematurity, which is a condition characterized by proliferative changes in the retinal vessels. Okay, that is followed by hemorrhage and peripheral separation of the retina. It is due to increased oxygen concentration or oxygen overdose and can be prevented by putting oxygen concentration at less than 40%. Okay, so the other complication that we can look at is physiological jaundice. This is due to immature liver where it fails to conjugate bilirubin and hence the bilirubin accumulates within the bloodstream. Otherwise, treatment for jaundice is necessarily phototherapy, exchange blood transfusion, and the early feeding. All right. The other complication that we can look at is necrotizing enterocolitis, okay, abbreviated as NEC. So serious conditions affecting the bowel during the first 3 weeks and the cause is unknown. Signs of this condition include baby vomits, bowel stained fluids, distended or may have a distended abdomen, brand and mucus may appear in stool. How this can be treated is oral feeds should be stopped, only IV feeding. Antibiotics and surgical resection of perforated and necrotic bowel can be done. It's also important that you take care of nutritional deficiencies that may be due to increased growth rates and lead to vitamin deficiency. Nutritional deficiencies that should be taken care of. All right, so since we are looking at low birth weight, prematurity, and postmaturity, so we have now to talk about postmaturity. So, talking about postmaturity here, we'll say this is a baby born after 42 weeks of gestation. That is calculated from the last normal menstrual period, and incidence is 10% all live babies are premature, while 5 are post-mature. Signs of post-maturity include red will appear normal, fontanelle, they will look nearly or they'll be closed, hair looks long and ears are normal, skull is hard. The skin should be dry skin, no ranugo, no veinix caseosa. Peeling of the skin and body is covered in a meconium stained lacquer. Limbs, there will be normal, nails grow over the digit ends. Behavior, mentally alert and behaves, the behavior is like a child of 1 to 3 weeks old. The trunk, the chest is strong, abdomen normal, breast nodules not formed. Okay. Umbilical cord is normally set, muscle tone is normal, genitalia is normal, and all reflexes are present. Okay. All right. So today we're looking at low birth weight, prematurity, and post-maturity. We are in the series of looking at pediatric conditions, and if at all you're finding challenges with any of the topics that we might have covered or we're yet to cover, please suggest on the video on this video link below, so that we can cover those topics with you and help you through your learning. So thank you very much.